All right, so we are on electrocardiography for the healthcare professional, chapter 8, talking about heart block dysrhythmias. So on the slide 2, learning outcomes, we're going to be describing the various heart block dysrhythmias, identifying the first degree atrioventricular or AV block, using the criteria for classification, and then we'll be able to explain how the rhythm may affect the patient, including basic patient care and treatment, and able to identify second degree AV block, Mobitz 1, using criteria for classification, and then explaining how the rhythm may affect the patient, including basic patient care and treatment. We'll also be able to identify second degree atrioventricular or AV block, Mobitz 2, using the criteria for classification, and then explain how the rhythm may affect the patient, including basic patient care and treatment. Also identifying third degree atrioventricular block using the criteria for classification, and explain how the rhythm may affect the patient, including basic patient care and treatment. So as we talk about the introduction to heart block dysrhythmias, so these usually occur when electrical activity has difficulty traveling along the normal conduction pathway. Ventricular depolarization is delayed or absent, and the degree of blockage depends on the cause of the delay or blockage and the area affected. There are 3 levels of heart block. And the 3 levels are first degree heart block, second degree AV block Mobitz 1, and second degree AV block Mobitz 2, followed by third degree block. So, applying your knowledge, what is the cause of a heart block dysrhythmia? And the answer to that is going to be that the electrical current has difficulty traveling along the normal conduction pathway. Alright, so then when we talk about first degree AV block, cardiac output parameters. So you're going to use observation guidelines to assess the blood supply to the vital organs of the body to maintain normal function. There is a delay in the electrical conduction from the SA node to the AV node, and this delay in the electrical conduction causes the impulses to take longer to reach the ventricular conduction system, and after the impulses reach the ventricles, conduction continues normally. So it causes a longer than normal PR interval, and this is what it would look like. So the rhythm is PP and the RR intervals are regular and constant. The rates are usually 60 to 100 for both the atrium and the ventricles. The P wave morphology. So it's usually consistent morphology and shape. And the P wave occurs before each QRS complex. There's usually the same number of P waves and QRS complexes. The PR interval is usually greater than 0.20 seconds, and the QRS duration and morphology are within normal limits, that's 0.06 to 0.10 seconds. So, the things that we should know about first degree AV block. Cardiac output is consistent with an underlying rhythm. We want to monitor for further degeneration and development of other heart blocks. Observe cardiac output parameters. Report developments that occur. Observation of the cardiac output parameters will help you determine how well the patient is tolerating the dysrhythmia. So true or false? A first degree AV block prevents impulses generated in the SA node from reaching the ventricles. And so we should know at this point that this answer is false. A first-degree AV block causes a delay in the electrical conduction, but the impulse is not completely blocked from reaching the ventricles. There's just that delay. Okay? What are some distinguishing characteristics of first-degree AV block? The answer is that the PR interval is constant and measures greater than 0.20 seconds. All right, so now we're moving on to second degree AV block, type 1 Mobitz. So usually these are blocked or non-conducted impulses, and this just means that the impulse occurs too soon after the preceding impulse, causing a period when no other impulses can occur in the ventricles. So if an impulse occurs too soon after the preceding impulse, it is not conducted because repolarization of the ventricles is not yet complete. When the impulse is blocked or non-conducted, the ventricles do not contract. So although the P wave is present on the ECG, there is no corresponding QRS complex. All right, so some electrical impulses are blocked at the AV junction region. And there are some types of second degree AV block. This is type 1, Mobitz 1 or Weckenbach, or type 2, which is just called Mobitz 2. Second degree AV blocks are the only blocks that have an irregular ventricular response. All right, so impulses for type 1 Mobitz 1, the impulses are conducted with increasing difficulty. Type 1, it can be caused by disease or injury to the AV node tissue that conducts impulses to the ventricular system. But each impulse is conducted more slowly than the previous one when the conduction rate becomes so slow that another atrial impulse arrives before conduction. The ventricular impulse is then dropped. So the PR interval increases until a QRS complex is dropped, and then it resets in a regular pattern. So it's similar like this. All right, and then type 1 criteria. So the rhythm, the PP interval is regular. The RR interval is irregular due to blocked impulses. The rate is usually atrial rate within normal limits, so that's 60 to 100. And the ventricular rate is usually slower than the atrial rate. Okay. The P wave morphology is going to be normal in size. It should be upright. And there should be one P wave for every QRS, but then there should be additional P waves as well. The PR interval becomes progressively longer until QRS wave is dropped, and then the cycle restarts again. QRS duration and morphology is usually 0.06 to 0.10 seconds, which, if you recall, that's within normal limits. All right, so what you should know, treatment is based on how the patient tolerates the rhythm. So the patient must be observed for signs of low cardiac output. Medication may be required if the patient experiences difficulties. The patient may show signs of low cardiac output if the rate decreases to 40 beats per minute or lower. The condition usually results from inflammation around the AV node. Often temporary, may resolve itself, and you do want to monitor for further progression to third degree heart block. Okay, so I'm going to have you identify this type of heart block or AV block. And this should have come up with second degree AV block type 1. So let's think about this. What are the distinguishing characteristics of second degree AV block type 1? So the answer is that it has a cyclical prolonging PR interval until the QRS is dropped. And then the cycle restarts or resets and it begins again. Okay, so you still have that prolonged PR interval. When the QRS drops, then that cycle resets and it happens again. Okay. All right, and then we'll talk about AV block, second degree AV block type 2 or Mobitz 2. And this occurs when a pattern exists, such as 2, 3, or 4 P waves between each QRS complex. The ratio is then included in your interpretation. So, for example, the rhythm might be stated as second degree type 2 with a 3-to-1. So that means it has 3 P waves to 1 QRS. Okay? So the AV node selects electrical impulses to block, and the pattern may or it may not exist. Frequently, it progresses to third degree AV block, and it looks quite similar to this. Okay. All right, so the regularity of the RR interval, it does depend on the unpredictable nature of the blocked impulses. In some cases, the RR intervals form a pattern. In the rhythm, the PP interval is regular. The RR interval may be regular or it may not. It may be irregular. The rates, atrial rate is usually within normal limits. The ventricular rate is usually slower than the atrial rate. Remember, that's kind of similar to Mobitz type 1. However, so in second degree type 2, the QRS complexes are missing, but whenever a P wave has an associated QRS complex, the PR interval always measures the same. So sometimes it doesn't have that QRS complex, but when there is a P that has a QRS, that PR interval that's able to be measured at that time always measures the same. So the P waves are normal in size, normally upright, and at least one P wave for every QRS complex, but there may be more than one P wave. So more P waves than QRS complexes. The PR interval is constant even after the QRS drop occurs. And the QRS is within normal limits, so we'll recall that that's 0.06 to 0.10 seconds. All right, so some things that we should know, because second degree AV block type 2 is highly unstable and it can progress quickly to complete heart block. Close observation and monitoring are essential. It is also critical that you be able to distinguish between type 1 and type 2. So that, again, it's a highly unstable dysrhythmia. You want to observe that patient for signs of low cardiac output. It's a critical condition that can progress quickly to third degree AV block or complete heart block. So these patients are in a very critical condition. So here are some differences between the second degree heart blocks. And although type 2 is considered more critical than type 1, both rhythms should be reported immediately to the physician. So type 1, the PR interval varies. It's a temporary condition. Type 2, the PR interval is constant. And it's a chronic condition or a more critical condition. So remember, the lengthen drop equals Weck-Bach. So that's that little saying that can kind of help you remember the difference between type 1 and type 2. Type 1 is Weck-Bach. So lengthen drop equals Weck-Bach. So remember that mnemonic to help you remember how to distinguish between second degree AV block types 1 and 2. So we have lengthen, lengthen, drop equals Weckenbach. All right, and then we talk about third degree AV block or complete heart block. Dissociative just means that it's not related at all. The atria and the ventricles beat entirely independently of each other. And all electrical impulses originating above the ventricles are blocked. There's no correlation between atrial and ventricular depolarization. The PP and the RR intervals are dissociative. So remember, they have nothing to do with each other, is pretty much what you're coming down to. Both the PP interval and the RR interval are regular, but the PR interval is variable because the atria and the ventricles are firing at different rates. So you see how we have this shorten, long, shorten. Okay. So regardless of the ventricular pacemaker site, the ventricular rate will be slower than the atrial rate. So the rhythm, the PP interval is regular. The RR interval is regular but different from the PP interval. The atrial rate is normally 60 to 100, while the ventricular rate can be 20 to 40 or 40 to 60, depending on the pacemaker site. So the P wave morphology. Not every P wave will have a QRS complex following it. However, the P waves are normal in size and normal morphology. They may even be buried in the QRS complex, or they may occur before or after each QRS complex. P waves normally outnumber the QRS complexes, so you're going to have more P's than QRS. Third degree heart block is the only heart block in which the P waves can be buried inside a QRS complex or a T wave. The PR interval, so it varies because the atria and the ventricles are firing at different rates. QRS duration and morphology. So all of the complexes have the same duration and morphology. They may be within normal limits or wider, depending on the location of the block. AV dissociation results in the loss of atrial kick. Your first responsibility is going to be to observe that patient for signs of low cardiac output. When that ventricular heart rate is 40 or lower, that patient may become unconscious or they may be unconscious. You do need immediate medical intervention, or you may need it. Rhythm strips should be mounted and identified in the patient's record. And so this is just giving us an idea of first degree, second degree 1, second degree 2, and then third degree, so that you can kind of see what's happening. Does that make sense? All right. So what are the distinguishing characteristics of third degree heart block? And it's just that the PP and the RR intervals are regular, but they're firing at different rates. Alright, so for our chapter summary, in heart block rhythms, the current has difficulty traveling the normal pathway. First degree AV blocks is a delay in conduction from the SA node to the AV node that prevents an impulse from traveling to the ventricular conduction system. Second degree AV block type 1 has blocked or non-conducted impulses from the SA node to the AV junction, also called Weckenbach or Mobitz type 1. Second degree AV block type 2 selects which impulses it will block, resulting in periodic missing QRS complexes, also called Mobitz type 2. And third degree AV block is complete heart block. All the impulses above the ventricles are blocked, so there is no correlation between atrial and ventricular depolarization. And that's the end of chapter 8. We will have time for questions later on this evening. If you do have any questions right now, write them down. And when we have our conference call, we will go over them. Thank you.